is your lunch talk today. My name is Solomon Asco. I'm the Principal Evaluation Officer within the Independent Evaluation Unit. We're so excited to have Dr. Kristie Ebi with us today, and thanks to Yo-Yo, our acknowledge for bringing her here. She'll be talking today about managing the health risk of climate change. Let me briefly give you some very quick biography of Dr. Ebi, and then I'll let you know how we're going to proceed with this talk. So Dr. Kristie is a director at Center for Health and the Global Environment at the University of Washington. She has been conducting research and practice on health risk of climate change and durability over 20 years, focusing on extreme events, thermal stress, foodborne safety. She has supported multiple countries in Central America, Europe, Africa, Asia, and the Pacific on assessing vulnerability and implementing adaptation strategies. She is a co-chair of the International Committee on New Integrated Climate Change Assessment Scenario. Her scientific training is she has a PhD and a Master in Public Health and Epidemiology, published over 200 publications last year. She has a wide range of expertise. We are super excited to have you here. The way we're gonna run this talk is we're gonna talk for about 25 minutes, and if there are any clarification questions, you could interrupt in the middle, and then we're gonna have about 30 minutes, 25 minutes for question and answer, and that's how we're gonna run. And the floor is to you.
Great. Well, thank you, and thank you everyone for coming. Really appreciate the interest. I want to start with kind of a definitional issue. So in health, we talk about health systems. And health systems have two big fundamental components. One is population health, used to be called public health. It's all the work that is done around the world to understand where we've got cases of disease, what the trends of those cases are, to take a look at the effectiveness of treatment, to make sure that we all are safe. So I don't know exactly how the Minister of Health is structured here, but often the Minister of Health is responsible, for example, for looking at food and water safety. There's lots of issues that we do in public health. Separate from that is health care. And in some countries, these are actually separate. So there's a Minister of Health that focuses specifically on population health, and there's a separate group that focuses on health care. In some countries, they're combined. And the health care is what you think. So it's all the health care facilities. And so when we think about health systems, we need to think about both components of that. And when we think about the health risks of a changing climate, there are a very wide range of health outcomes that are sensitive to weather and climate. And so anything that's sensitive to weather and climate can be sensitive to climate change. And I'll mention a few as I go through. It's also important to know that it's not just climate that drives these health outcomes, that there's all kinds of conditions. And you can see here there's environmental and institutional context, and there are behavioral social context that determine the ultimate pattern of disease you see in a particular location. So we need to take a look at these upstream drivers of health. We need to take a look at, for example, water safety and who runs the water safety plans. And we also need to take into account the vulnerability of the local population. So I fundamentally believe that climate change is going to really change how we look at health, how we do our basic jobs. When you look at what is done in population health, it's primarily a top-down activity. There's a problem with Zika. Lots of money is spent, a vaccine is developed, and you go out and vaccinate everybody. It's discovered that exposure to lead causes all kinds of health outcomes that you don't want to see. So a series of studies are done, an exposure-response relationship is established, and the same exposure-response relationship is applied in every location to say, here's how much you need to reduce lead in gasoline, lead in paint, other exposures to lead. But in this case, the underlying vulnerability of a population, including their geographic vulnerability, determines what you'll ultimately see in terms of a burden of disease in a location as the climate continues to change. So we have to take this local context into account. It makes the work that needs to be done in climate change both more interesting and more challenging. And to emphasize that there's upstream drivers, this is some work that was done on actual observed emerging disease threats in Europe. And the authors, Jan Siemens and his colleagues, used a technique that's used in genetics to see how closely related different drivers were of these actual outbreaks. And so the number one driver was travel and tourism. Global trade, food and water quality, surveillance, which is traditional population health, comes in here, climate and the natural environment. But you can see that the major drivers are outside of public health. That there's no ministry I've worked with that actually sits down and talks with the ministry who's got anything to do with trade or tourism. But you have to understand that if you're going to be effective in trying to manage particularly emerging infectious diseases, which are becoming critically important as the temperatures go up. When we think about all these health outcomes of a changing climate, health is in a different situation than most other sectors. All the health outcomes we're concerned about are current problems. We're worried about malaria, we're worried about dengue, we're worried about foodborne disease, we're worried about undernutrition. Those are problems right now. And because they're problems right now, we also have a pretty deep understanding of which groups are most vulnerable, because that's part of what we do in population health. On the other hand, all of these policies and programs were designed without taking climate change into account. And adding climate change is not pretty easy, I have to say. That in many places trying to do that is really quite complicated. So there's a lot of work that needs to be done in bringing climate change into what is being done in health systems. But the fundamentals of what you're going to do will be pretty similar. What you're going to do for malaria is going to be the same in a changing climate. You're going to do it in different places, different times of the year, with different intensity.
Great today.
Yeah.
It's a bit of exercise in between.
Oh, well. I understand you're recording this. It will be interesting. And so ultimately what we're trying to do is build climate resilient health systems. And this is a graphic put together by the World Health Organization in this operational framework. When you look at health systems, there's basic building blocks. So WHO has got 6 basic building blocks. In the US, the CDC has got 10 basic building blocks. They're all sort of the same. But around these building blocks are some specific activities that need to be undertaken to increase resilience in the health system to a changing climate. So we've got a pretty well articulated agenda of what needs to be done for research and for adaptation, and as well as for mitigation. And we can come back to this if you've got a question on these. I'm not going to read going around the circle. I'm just going to focus on a couple of these to hopefully generate some discussion. The one big category is a health workforce who has the knowledge and the tools that they need to address a changing climate. On the left, there's a lot of work going on vulnerability and adaptation assessments. Countries are starting to engage in this process. There's guidance from the World Health Organization and from others. Frankly, when you look at all the guidance for vulnerability and adaptation assessments across all the sectors, they're all kind of the same. But this is what is being used right now. This is part of a project funded by the Asian Development Bank in Cambodia, Laos, and Vietnam. And we're going through and during the process of completing their vulnerability and adaptation assessments. At the end of which they come up with prioritized adaptation options of what they need in the immediate future, so what's urgent and immediate, what's in the medium term, and what's in the longer term. You also need to have leadership and governance, and frankly, that is a challenge in this area. When you look at all these climate-sensitive health outcomes, they're just about everything a Ministry of Health has to deal with. And ministries are designed so there's a malaria control program, a dengue control program, a maternal and child health. And so you've got all these programs, and climate change cuts across all of it. You're asking ministries to coordinate in ways that they often don't, rarely do, as a matter of fact, in most places. And this is just an example from Bhutan. They received funding in a 7-country project that was funded by the Special Climate Change Fund a few years ago. It was the first international project on health adaptation. And Bhutan really did a lot of work in that project, developed very close collaborations with their meteorological services and with the folks who work on agriculture, so that they can start working together on designing programs to make sure that they're managing risks before they become too significant. You need health information systems that effectively manage these risks. There's lots of components to that. I mentioned the vulnerability and adaptation assessments. Vulnerability and adaptation assessments feed into the health components of national adaptation plans. And so there's a few countries that have completed their national adaptation plan for health. These are feeding into whatever is being done at the country level on their national adaptation planning, which, as you know, is part of signing off on the Paris Agreement that countries have agreed to provide national adaptation plans. This, trying to find something to put in for surveillance. So surveillance in health means something a little bit different than what it means when you read about Google and Facebook. When we think about surveillance, we're talking about how you go out and collect data. If you're worried about dengue, which is a problem in Asia and has appeared here in Korea, how do you go about finding out if you've got dengue? And there's 2 basic ways to do this. One is active surveillance and one is passive surveillance. So all countries have a list of diseases that medical doctors are required to report. So if you get a case of dengue, you go to your doctor, dengue is diagnosed, you may be required, the doctor may be required to report it to the national government. And that's a passive surveillance system. You just wait for cases to be identified. The challenge with that is when something new shows up, it can take quite a long time before that shows up in the national registry. So active surveillance is when you go out and actually look for cases. So you go out and you take blood sera from people and you check for antibodies and you try and figure out how many cases there have been. So it's the 2 major categories. As you can imagine, active surveillance is a lot more expensive than passive surveillance. It's also a lot better. Everybody gets one unreadable slide. This is going to be mine. This is something that was done across 14 countries in the Pacific. I'm not intending you to read it. What I want you to look at is this is a list of all the climate-sensitive health outcomes of concern in the Pacific Islands. Here's the islands. And just look across. So this is extreme weather. This is water security, food security, vector-borne diseases. So you can immediately see that there's issues that cut across a region. And so one of the lessons learned on the various projects is regional approaches will be very effective in this area. The Asia Development Bank project, Cambodia, Laos, and Vietnam, all have problems with dengue. You don't want 3 different dengue control programs that don't talk to each other. You want to help facilitate those regional approaches. And further, the ministries of health really like working together. We talk all the time in adaptation about learning by doing. There's nothing better than working with a group of your colleagues in another country to see how they're doing it, what ideas they've come up with, what works for them that you can try in your own country. So the projects that have been done really reinforce both the work that needs to be done within the country, but also the regional approaches are really helpful to overall strengthen systems. It's also a lot more cost effective. Early warning systems are something that will be incredibly useful in this area. And let me go through and explain this a little bit. I talked a little bit about passive surveillance. So this figure in the pale pink, it's your traditional outbreak. When you have an outbreak of disease, it almost always looks like that. It may have bigger tails, but basic structure is that. When you have passive surveillance, the person who is the first author of this is a close colleague of mine. Corey put the first case down here. When you actually see outbreaks that occurred, often the first case is detected somewhere over here, somewhere past the peak. And then you initiate your response, and your response is somewhere on the downslope. So we know that passive surveillance can help. It can shorten an outbreak. But in actual fact, he's pretty optimistic about when you have that detection and when you have that response. And it depends on the disease, on how long the lag is between there. What do you need to do? When you see Ebola, how long does it take to get the units out there that you need to get out there? And so there's different lags for different health outcomes. But if you have an early warning system, you can still have passive surveillance, so it's back here, but you can use environmental information. And that environmental information can tell you about when you're likely to have an outbreak, where you're likely to have it. An example is Singapore. There is dengue in Singapore, a place where one wouldn't have expected a strong environmental signal for dengue. Minister of Health in Singapore told me several years ago they've got 3 seasons. It's hot, it's really hot, or it's really, really, really hot. And it's humid all the time. And mosquitoes love hot, humid environments. So wouldn't expect a strong environmental signal. In fact, there is one. And so a PhD student did analyses with the data, found a very strong signal with temperature and precipitation, and has designed an early warning system that can give warning 4 months in advance. The mosquito that carries dengue is an urban mosquito. Anybody paranoid about mosquitoes? It will fly about 1.5 kilometers to bite you. It will bite you over any other mammal. It really is out to get you. And it lives in our urban environment. It breeds in the water in the bottom of a flower pot. And it's almost impossible to control because it breeds everywhere. And so you have to clean up all the breeding sites, and it really will go out of its way to bite people. And that's all based on laboratory data. And when you go out into the real world, I have not done this. Colleagues who are entomologists have done this. If you go into sewer systems, there's millions of mosquitoes. It's warm, it's moist, it's a great environment. They really appreciate it very much. So thank you. And in big cities, they put grates, right? So there's grates in the sidewalks so the mosquitoes can come up and bite people and go back down and lay. We've got an infrastructure that supports dengue. And that's just going to get worse with climate change. But if you've got 4 months, you can warn pregnant women. You can make sure that people take precautions. They clean up all the breeding sites around their living spaces. There's lots you can do in 4 months. And so, in fact, you then can see a very limited outbreak for what would have been a very large outbreak. Overall, there's about 400 million cases every year of dengue. It's a major issue in public health. I put this in because, number one, it's really important, and number two, there's been so little use of environmental information in health. And so there's a real opportunity to develop these for a number of situations, which will, of course, if you take climate change into account and do iterative risk management, will make us better prepared for higher temperatures and more humidity. Another big category is effective delivery of our health services. One component of this is disaster risk management. There's a lot that needs to be done in that space. I do work, as I mentioned, in the Pacific. Most of the healthcare facilities are in coastal zones. Storm surge, sea level rise are a real big challenge for those health facilities. And there's a bunch of health facilities that are going to need to be moved, that they're just not going to be able to really shelter in place in a changing climate. I mentioned modifying our policies and programs. It's a lot of the work that I do working with the ministries, and it gets down into the details of what is the program, how does it work, who's responsible for it, what do we think is going to happen with climate change, and how can we modify that so that you're prepared as temperatures change. I mentioned before these upstream drivers of health, like travel and tourism for the disease outbreaks in Europe. We have to look at who is responsible within a country for managing agriculture, for managing water, and to see how to facilitate collaboration across these different sectors. for reasons I just can't wrap my head around. When you look at what goes on with agriculture, people in agriculture go to crop yields, and then there's a valley of death, and then there's people who work on nutrition, and the two shall never meet. And trying to help bridge that is going to be a challenge that we're going to have to address soon. And then finally, climate resilient and sustainable technologies. I think I've got a slide showing that. So again, back to the healthcare facilities. This is work we just did for the 4th U.S. National Assessment, showing 2 places in the U.S., showing healthcare facilities, different flooding categories with hurricanes, and just emphasizing everywhere has got healthcare facilities in floodplains that will have a challenge particularly with higher hurricane strength and with more rain as they make landfall. And when you address this, there's a real opportunity. So this is an example from the British Virgin Islands. After Hurricane Irma, this was really significantly damaged. And so there is a major effort through the British government to rebuild that. But they built it back better. So they took into account the layout, they took into account where hurricanes approach, what the wind strengths have been, and they made it green. So they put in solar panels in a way that they can now really lower their greenhouse gas emissions. At the same time, they've got a much strengthened healthcare facility. And most of the work that's being done right now in health is really focused on current climate variability. There's been really limited effort to actually pull climate change into what they're doing. That there is a mantra that's been said for 25 years in adaptation, that if we can adapt to current climate variability, we'll be better adapted to climate change. But certainly for extreme events, the last 2 years have shown that's not true. And so thinking about how to actually prepare health systems. So one approach that is starting in the health sector, and a couple other sectors are starting as well, is doing stress testing. It's the same kind of thing that the military does, what the banks are doing. You create hypothetical situations, and could you manage it? And the answer always is no. And you find out people learn the same lessons from all of these kinds of stress testing of there's one critical person, they're somewhere with their cell phone off and nobody knows who the second in command is. You know, the usual stuff that people find, everybody learns over and over again. But we've also seen several examples of some pretty extreme events in the last couple of years where having this kind of foresight would have really made a difference. Why the military and the banks do this regularly. And so we need to look at more systems-oriented, transformative approaches to the health systems and not just look at what current experience is. And then finally, the big category is finance. It's for a field that is recognized as being critical to climate change. Nobody's investing in it. There's no research. There's no adaptation funding. And no is a slight exaggeration, but it's not much. So this is a budget allocated to health out of total adaptation resources in the Pacific. And almost all of this is one project that was just funded. When you look in other parts of the world, the adaptation funding going to health is 0.5%. Incredibly tiny. And there's reasons on both sides. There's reasons why health hasn't come forward, and there's reasons why the funders and the donors haven't funded. And it's an impasse that needs to be resolved because the critical needs are rising in countries. We do know people are suffering and dying right now from climate change. And we do have a moral obligation to try and help. And then finally, when you think about the health risks of a changing climate, or even when you think about climate change, I hope you think about children, that 85% of the health risks of a changing climate are in children. And so they're the ones who are being affected the most. And do think about children as you're working on your various programs. Thank you.
Thank you. Hey, no, you did it very good here.
Oh, good. Okay.
Thank you very much for that precise and very practical presentation. I would open the floor for questions. We might collect...
Or answers. I'll take answers.
We might collect the question. You could respond in clusters. Yeah, if you like to.
We've got a mic that might or may not work.
I have a question on the role of pharmaceutical and pharmaceutical industry in the preparedness for climate change. Is there a roadblock, or because right now we know that, for example, supplies for some medications, vaccines are stressed by these industries? I am not very positive that they would be very inclined in cooperation on the preparedness of climate change. Do you have some insight on this?
Yeah. We could take more questions if there is capacity here from us here.
Thank you. Thank you, Dr. Ebi. It was really nice presentation. And I think it's one of the really critical topic I also encountered during my graduate school. My question is, how do you define especially in a very complex situation, how do you define this disease or any kind of vector disease? It's because of the climate change, not because of the water pollution. For example, when we're encountering projects from developing countries, and their situation is much more complex than developed countries. And in that case, what would be the indicators and what kind of initiative or situation we should think about before separating data of big climate change data as well as the data related to the other specific issues? Thank you.
Jeremy?
Hi, thanks very much for the presentation. My name is Mark. I'm an audit at GCF. Just wondering about diagnosis. From a time in Vietnam and Laos, if someone had dengue fever, almost all doctors and quite a few non-medical people knew what the symptoms would be and knew to recognize it straight away. If you get it in Korea, are people going to know what they're seeing, and how do you spread the knowledge for rapid diagnosis?
Go ahead, yeah.
All right, those are all great questions. So I'll try to do these in order. So the questions on the pharmaceuticals is, to my knowledge, they're not doing anything in this space. There is an organization called Global Good that's funded by the Gates Trust Fund. It's not the Bill and Melinda Gates Foundation, it's the trust fund. And they're working on issues like vaccine transport, because so many of our vaccines, you have to have a cold storage from the time it's created until the time you inject it. And that is a really, really big challenge everywhere. I remember being vaccinated in Rome at FAO and made a comment about yellow fever has to have cold storage. And the nurse just went off on the Italians and how they take the vaccines out of the refrigerator to put in their wine when they're having a party. Too much knowledge. But so they are working on some solutions where we're going to need to have that cold storage and have some pretty interesting technology. And at some point, the pharmaceuticals are likely to come in to go to the question on diagnosis. There's very few rapid test kits. And so when someone comes in, there just are not rapid test kits to figure out what somebody has. And some of the ones that we have, to be frank, are really poor. That the false negative rate could be 50%. Okay, why even bother if there's a 50-50 chance they're going to get it right or not? So rapid test kits will be needed. And in some of the adaptation projects, they use money for rapid test kits because concern about outbreaks, particularly of dengue, and just not being able to manage. We also really need something like that in Africa. When you look at the data on dengue, there's very few cases of dengue in Africa, which tells you that there's a lot of misdiagnosis. And so there's a lot of drugs being used because the presumption is a child has malaria when they probably have dengue. So there's lots of opportunities in that space. Whether there's going to be new drugs, we're having all kinds of problems with antimicrobial resistant drugs. And so hopefully they'll become more proactive in that space. as long as I'm doing the diagnosis, there's been some really interesting efforts from medical societies who've put together documents about climate change and health that they're distributing across their medical society to help increase awareness of diseases changing their range. And a lot more needs to be done in that space, but there's some really energetic physician groups that are trying to make that happen. There's also pediatricians and others are also trying to raise awareness about diseases changing their range. A lot more needs to be done, but it started. And then the question you asked is a really good question. It's about the difference between climate change and development. And if you look at where the health sector is as opposed to, for example, ecosystems, where we all have multiple drivers, they're all complex systems, we have pretty short data series. And so the formal process of detection and attribution is more complicated for health. So what we do is look basically at first principles. So for example, water pollution, when you look at various waterborne diseases, a lot of them, the rate at which they replicate is temperature dependent. Water temperature goes up. I can't say that's due to climate change, but the water temperature went up. And so there's lots of instances where you can actually take a look at what's going on and saying, yes, most of this is likely due to climate change. There's a couple of natural experiments that have happened basically in the Baltic with the Vibrios, Vibrio parahemolyticus and Vibrio vulnificus, and showing as the sea surface temperature has gone up in the Baltic, the number of cases have gone up. And so you can do in some places you can do detection and attribution. But it is a challenge. And as we accumulate more information, unfortunately, it's just going to be a whole lot easier to do detection and attribution. Got that one?
Thank you. Let me ask one question and let me use you said at the end of your presentation, investment in health sector from adaptation point of view is very limited. You did not indicate the reasons why. Is that because the value for money or the rate of return on investment in another sector, in livelihood, food, other sector is higher vis-a-vis investing in the health sector? Or what like the complementarity, the intersection with the other sector? And if you could say to the GCF task manager here who designed a project, where could they put their money on? What kind of ideas out there that need to be upscaled from your experience? That's the first question. Second question, in terms of measurement of this health resilience. Resilience is a complex concept. What is your experience in terms of how one can effectively measure in a quantitative manner this complex nature? That's my question. I'll open the floor. If others have any other question, then you could respond together.
I have quite a similar question. If, let's say, GCF would be making an allocation of $200 million, what would be the intervention in health and climate change you would support? And the second question is the role of short-term pollutants in urban areas and why we cannot find a city who has handled that problem properly. And it's a public health issue related to the urban infrastructure.
Okay.
Great. So I'll start with the first question, and my answer is going to be, I think, different than you expect. So, as I said, it's a two-way street on the funding. On the health side, is the overall awareness about climate change is really low. And so when you talk with ministers of health, they really just don't quite get the issue. Some do, and some are doing really a terrific job. But there's been 20 years of the World Health Organization trying to raise awareness. And it is making a difference. But when you look at ministries of health, they're always cash strapped. And they've got an outbreak of this, they've got something else going on, they've got a high burden of HIV/AIDS. You name it, they've got lots of problems. And they don't see climate change as an immediate threat. A lot of what they hear is basically through newspapers. And so there's been really low awareness on their side. And that is a really big challenge. And there's work going on to fix it. And to partially answer one of your questions, is one way to do that is to do these vulnerability and adaptation assessments and to do the national adaptation planning. That it sounds very process-based, but it ends up with real advocacy. So an example from that is in the 7-country project I mentioned, there was questions about how you measure the effectiveness of this project, and the project was through UNDP to WHO to 7 countries. And it was early days. So it was decided to use a UNDP tool that looks at a vulnerability reduction. So you do an assessment at the beginning, in the middle, at the end, and you look at how much have you reduced vulnerability. And in fact, in several of these countries, the vulnerability went up. The assessment of vulnerability went up. Because at the beginning, everybody thought, oh, we're not that vulnerable. And they started working on climate change and went, oh dear, right? It's a lot worse situation than what we thought. And so going through that process makes a really big difference for awareness within the country. It then means the minister is really engaging across other ministries on this issue to try and make sure that they do address these upstream drivers. And then on the other side of it, from what I've seen from the donors and from different funding organizations, is health is off on one side. Health takes care of itself. If there's some problem, the health sector comes in and addresses it. And so the other sectors see their own priorities and assume that somehow WHO is going to magic the money so that WHO can help countries manage these risks. And that just isn't the situation. And so there's been misconceptions, kind of lack of good intentions in a couple places on both sides. When you go and look at the NAPAs that many countries put together, quite a few of them that I could name have a section on health that was written by an environmental consultant who actually knows nothing about health. They didn't even go and talk to the Ministry of Health. So you've got these structural challenges that people are now working really hard to try and address. So it's not the value, it's not that anything's more important. When you look at the nationally determined contributions, well more than half of them put health in their top 3. But then it doesn't go anywhere else. So that seems to be a real challenge that needs to be addressed. You're asking about indicators. Resilience, of course, is very difficult to measure. On the one hand, health has long experience with indicators. We measure how many people have various diseases, how many people die. So we've got all these indicators. But they're not good, from my perspective, they're not great indicators for resilience because they're post hoc. So after you have an event, we count how many bodies there were. Well, it'd be really nice if we could prevent that. And so there's work in all of these adaptation projects to put in process indicators. Do you have an MOU with your Met Services? Do people actually sit down and talk to each other? You've got to play it. It was in the United States in the 90s. A colleague went out and reviewed how many heat wave early warning system plans there were in major cities in the U.S. And it was only 12, which is really small. And I think it was 9 of them were just a plan sitting in a drawer. They never implemented it. So those kinds of simple indicators of, are you doing this? Are you meeting with the people? Do you have the collaborations you need to have? And making sure that this becomes part of a job in a ministry. So it's not just a tag on, but it's really part of somebody's job. Their mandate. And you know that when that person leaves, the next person will come in and take that over. Which reminds me of another comment I wanted to make, that one of the weaknesses from my perspective of the World Health Organization is they don't work with universities. And so one of the structural changes that needs to happen is just about every place I've been, universities want a course in climate change and health. And they don't know who could possibly teach it. I was in Uzbekistan, talked to the head of the major medical college. They want a course in climate change and health. Where can I find somebody that speaks Uzbek who can give this course? And so there's this massive need for getting the universities trained so that they can provide the people to the ministry, to all the health NGOs who already have the basic information. So it's an area where more work needs to be done. The short-lived climate forcers are really important. Massive investments going into that. Absolutely massive. Why people can't get that right is a really good question. It's not my area of expertise, but spending time with people who work on that, it is a really big challenge. Another piece of that is that when you look specifically at mitigation, that almost all the mitigation policies have health co-benefits. And there's a growing and pretty robust body of literature that's showing that when you take into account avoided hospitalizations and premature mortality, the value of mitigation is about the same as the cost of mitigation. So we should be mitigating for health. And there is growing efforts at trying to get that message out. And that will help also with the short-lived climate forcers to make communities, legislators understand we should be doing this because people suffering and dying from air pollution is not acceptable.
Thank you very much. A last round of questions, if there are any. We have time for.
I know.
And
methodology
for discuss.
No, just a minor one. To say you referred to communities of color in your presentation as being more vulnerable. Who are you referring to? Is it in the U.S. context? Or
That was for the U.S. National Assessment. But it's true around the world. You know, it's true that when you look, who's most vulnerable are the poor and the marginalized. Right. So the poor and marginalized in many countries are ethnic groups of some sort. There's a whole range of groups that are poor and marginalized. They're poor and marginalized for a reason, and that's often cultural reasons within countries. And so in the U.S., it is the communities of color, but that's not unique to the U.S.
I was curious about the last point you made about this value for mitigation project, the opportunity cost of the value of this health. Is there like quantified now in a much more robust scientific way that one could use as an argument for a co-benefit of mitigation project? Is that widely?
Yeah. So the answer is yes, the science has moved forward quite a bit. It needs to go even further. There's lots of studies right now that are quantifying health co-benefits. The problem is they're all doing them differently. So we just hosted a meeting at Wellcome Trust to try and help resolve some of this disparity across studies so that we can start adding them together, because we need to do that. And one of the things we proposed back to the Wellcome Trust was to think about writing some guidance documents so that this doesn't have to be a big modeling exercise that's done in a couple of groups, but something where if you've got a guidance document that can be done in other locations without having to have such intense information data, I guess.
Yeah, 5 minutes. Yeah.
Oh, wow. I have so much to ask. But, I said before, I mean, one thing that we always have to do is, and you're perhaps thinking of, well, there's urban mitigation and adaptation. And I'm in full support, I mean, with mitigation, health as a co-benefit. And also I want to develop a methodology in getting health economic benefits recognized as efficiency and effectiveness of our proposals. And I think that would be transformational, but I don't know how we do that. And so one question would be, what's the paradigm shift for the health world? Certainly in adaptation, what would be an intervention, or what would be a process?
I would start with the basics of, I've helped WHO run a dozen workshops in regions. There's almost, I can count how many countries where somebody in health that actually knew somebody in their med services. They just don't even know the people in their own country, and even in small countries. And if going through this process, which I understand is not very exciting, it does take a fair amount of effort, and it's not cheap to try and make these collaborations happen, but you can start thinking about what it would look like. For example, in Indonesia, the previous prime minister put climate change at the top of his agenda, and he had basically all the ministers reporting to him in a climate change group. And so they spent years collaborating very closely with each other. And I was in Indonesia for various reasons, and I went to a farmer field school where they're talking about paddies and the problem they've got with saltwater intrusion into paddies, with a representative from the Ministry of Health. And the farmers brought up health issues. And the representative of the Ministry of Health said, great, we're going to set up a program, and we're going to come in and we're going to work with the farmer field schools, and we're going to address not just agricultural issues, but we're going to address health issues at the same time. And that's where you can start getting transformation, because it's efficient, it's effective, and people are getting what they need by this collaboration across the ministries, across the NGOs, across others, instead of having so many separate interventions that may or may not be effective. We often don't really measure how effective they are. So it's not much of a, here's a technology that's going to transform everything. There are lots of technologies that we do need to try and address diseases changing their range. I didn't mention that what I think the biggest health risk of the changing climate is going to be, it's not because of climate change. It's because of rising CO2 concentrations. So CO2 concentrations, higher CO2 concentrations, reduce the nutritional quality of wheat and rice by quite a lot. They reduce protein, they reduce all the micronutrients, they reduce the B vitamins. And we estimated that just in Asia, just looking at the low-income portions of the populations in Asia, towards the end of the century, we're talking about affecting 600 million people. It's going to be a huge, huge issue. Technology is really needed for that because there's no obvious solution. Genetic modification is not going to get at that. So we've got big technologies. And think about how much more effective we could be if we're in a situation where people in health actually work with the people in agriculture to make sure it's not just we're looking at how many calories the child has access to, but the quality of the food that they have, to make sure that they've got the best development that's possible. So starting with building the foundations here will create lots of interesting opportunities just by having those intersections across the sectors.
Yeah, 5 minutes to go.
Do I have to hurry then? Right? Okay, sorry. Yeah. I've actually got two questions. One refers to what we've just been discussing, that you've been alluding to the fact that health is in particular an issue for most vulnerable groups. And I was just wondering, looking at our environmental and social safeguard standards, when we look at the social component, we often lag behind a little bit because it seems to be more complex and more, has different layers when we look at that. And I was just wondering what your recommendation would be should we also look at health and the health issues related to that, and the safeguards related to that? And my second question is a bit of a different question. You shown in your presentation the Pacific region and that study that has been done, that it seemed to be more of a transboundary issue when it comes to climate risk or climate health risk and related health risk. So here, and then at the same time, you spoke as well about NAPs, so where we could look at a national level. So I was just wondering, could you put this in perspective? What seems to be more urgent or more important? Because just to see from the GCF perspective, we have yet to look at the cross-region problems. We'll try to have projects in regions, but we, usually if we're looking at a country ownership approach, that's how we work. So thank you.
Last question here. That will be the last. Yeah.
So in the first question, absolutely. I was a reviewer for a while of the PIFs for the LDCF, and frankly, it was appalling. There were quite a number of proposals that came in for ecosystems that were focusing on issues around like irrigation in places where we've got high burdens of malaria. And seriously, we're not spending adaptation funds to kill children. There is a very well done study quite a few years ago in Ethiopia. Microdams were put in to address food security issues, and hundreds of children died from malaria. And that we just can't do that, right? It's not that hard. In that case, no one ever talked to the Ministry of Health. It would take about a 5-minute conversation to say, if you're going to add irrigation in that area, well, we've already got the Anopheles mosquito. Part of the cost of the project is bed nets and a series of other activities. We know that, right? So it's just the cost of doing business, and it's not hard to figure that out. And to your second point, it's a challenge to try and prioritize one over the other, but certainly I would start at the national level, but then looking at where you're spending resources. And again, I'll just go back to Cambodia, Laos, and Vietnam. They've all got problems with dengue. And you can be more efficient in the funding, and you've got opportunities for experimentation. We've got different approaches to a dengue control program. Why don't we try them in the 3 countries and see what works, and then set up a collective system? But that has to be based in the national understanding of what their risks and their vulnerabilities are. And you will find places where then, once you've got that national work done, there'll be easy synergies. There's not always going to be synergies. There's going to be unique issues in various places. Bangladesh and saltwater intrusion in paddies is a real serious issue, but that doesn't reach across that far into Southeast Asia. But there are issues where you can start looking at a regional approach, and I think you'll find that it'll be a lot more cost effective to do it that way.
Thank you. Thank you very much. We appreciate your talk and for the lively discussion. And let's give a our talk. We'll have another line talks next month as well, line up on health-related issues. So we will invite and welcome you, and we like to.